record, we will make this Lunch and Learn available after the webinar presentation. So welcome to the Ohio School-Based Health Alliance's 2024 School-Based Healthcare Educational Series, Understanding School-Based Telehealth. We are a statewide organization created to advance and support the sustainability and expansion of school-based healthcare. And we are a state affiliate of the National School-Based Health Alliance. This is our vision and mission at the Ohio School-Based Health Alliance, focused on improving access to comprehensive integrated health services through school-based healthcare to advance equity and improve health and education outcomes for students, their families, and communities. And here are our areas of focus at the Ohio Alliance. We are focused on capacity building for our school-based healthcare partners across the state, policy transformation, including educating and advocating for a strengthened school-based healthcare infrastructure, and data tracking and evaluation. As a result of participating on this webinar today, we hope to accomplish the objectives that you see here, and we'll be asking you to take a short poll after the presentation to ensure that we have met these objectives. Love to introduce our speaker for our Lunch and Learn today, Luke Wortley, who is the Program Director at the Upper Midwest Telehealth Resource Center, which serves as a resource for Ohio and surrounding states on telehealth services. Without further ado, over to Luke.
Next slide, please. So welcome to today's Lunch and Learn. I'm very excited to be here. This is the unique intersection of the two areas of my personal and professional life that I've spent the most time in here, where I've been working with the Upper Midwest Telehealth Resource Center previously as a coordinator since 2016, and now as director since about this time last year. But I also come from public education as a literacy intervention coach and an after-school program coordinator, as well as a high school Spanish teacher here in Indianapolis. My partner's a middle school English teacher, so I'm really passionate about the intersection of providing vital services for youth in the school building, especially for rural and underserved populations, as well as our urban centers. So next slide, please. Just as a disclaimer, the Upper Midwest Telehealth Resource Center is funded by the Office for the Advancement of Telehealth, which is a subsidiary of the Health Resources and Services Administration, or HRSA, which is a subsidiary of the Department of Health and Human Services. Next slide, please. So for those of you who might be unfamiliar with what we do, we are, I think the best way to most succinctly describe it is a telehealth clearinghouse. We cover the 4 states of Illinois, Indiana, Michigan, and Ohio, and we are a program of the Indiana Rural Health Association. Our job is to try to not only create resources, but provide a nice convening space for people who are interested in vociferously advocating for more equitable distribution of resources and access to care, regardless of geography. Next slide, please. So what does this mean? We are also part of a national consortium of telehealth resource centers. So if you end up having colleagues or move to a different region, or are looking for cross-sectoral collaboration potentially outside of those 4 states that I just mentioned, there are 12 regional telehealth resource centers that cover the entire country, and you'll see that on the next slide, please. So each region, as well as the U.S. territories, including the Virgin Islands, Guam, Puerto Rico, and most of the Pacific Basin, are all covered. We also have 2 national centers. At the top there, we have the Telehealth Assessment, or the Telehealth Technology Assessment Center, TTAC, which is located in Anchorage, Alaska, and the Center for Connected Health Policy, located out in California. They specialize in policy monitoring at the state and federal level. Next slide, please. So when I say we provide resources, this is just one form of those resources we provide, where we actually do individualized education and outreach. But we create standing resources, including reimbursement guides, uh, as I said, policy monitoring and regulatory concerns. We try to promote awareness of digital health and health equity broadly, and create a collaborative space for people to convene. Next slide, please. We also do offer individual technical assistance. That's kind of our bread and butter in terms of what we are legislatively funded to do through HRSA. This can range from telehealth 101. You might have a small independent clinic that is just getting started in the digital health space, and they kind of need to know where to go. And that can range from that on the very basic end, all the way through workflow optimization, down to really, really esoteric billing and coding questions, cross-state licensure, et cetera, et cetera. We also provide a lot of resources via our YouTube channel, our podcast called A Virtual View, which you'll hear about later, and other resources housed on the website. And with that out of the way, next slide, please. We can go ahead and get into why we are all here today. So I want to start by maybe giving everybody a brief overview of when to start thinking about how to provide telehealth or digital health services in schools, and then where do you start. From there, we'll talk very briefly, because we don't have more than an hour today to talk about what kind of equipment you might need, personnel, some best practices. We'll talk briefly again about legal and reimbursement considerations that you definitely want to anticipate before you begin, and then take a look at a couple models for success that are both regional and I think maybe demographically proximal. So next slide, please. We'll begin with where to begin. So obviously there's a lot of pre-planning and preliminary work that goes into creating your logic model or work plan, or whatever it is you're going to use as your kind of guiding documents to begin work on a digital health integration into a school-based healthcare setting. And it's entirely dependent on partnerships internally within the school building, externally in the community, sometimes even further away from just the community in which it's based, just because we do have the capacity for that with digital health intervention now. And so you can't, it's hard to kind of build the plane as you're flying it, right? So trying to anticipate as many of these needs as possible, clearly define your roles and responsibilities of your partners, and then to be able to convince people to come to the table in the first place is kind of where you want to start. Next slide, please. So when you establish those partnerships, I think that this might go without saying, but I think it's worth saying anyway, which is obviously you need to have school administration, faculty, and staff at the table to even begin the conversation, right? People who work in the school building, who are intimately familiar with those processes, the physical space, and how that can be utilized is going to be crucial. And preferably, I mean, this is best practice, but sometimes it's not necessarily always available, especially in the behavioral health realm. As we know, our 4 states outside of the major urban centers are quite rural, and many of them do not have a practicing psychiatrist or psychologist, and may rely on other forms of referral or getting access to mental and behavioral health services. So you want to have a local provider as much as possible, but sometimes we know that for certain specialty areas that might not be possible. You definitely want parents, guardians, community members. You want a staunch advocate in the community, somebody who believes in the viability and the necessity of offering digital health in schools, and somebody who really understands the kind of role and niche that it will occupy within the school building. Social services, of course, for our most vulnerable populations who might need referral beyond the traditional continuum of care, they're going to be extremely valuable partners as well. And then, we here at the Telehealth Resource Centers always maintain that whenever you initiate any kind of implementation project, it's nothing about us without us. And I think you need to have student input into this, just so that they very clearly understand what the point of the service is, and maybe being able to gauge what is most important to them in a digital health setting. Next slide, please. So I think we know that that's where we start, but when do you actually start getting people together? I think the way that you decide that you're ready to start bringing people to the table for meetings that are going to be not only preliminary and planning in nature, but also moving toward that implementation process is going to be when you have accurately anticipated the various needs of the stakeholders involved. And for us, and I guess I should note, back in 2016, I was part of the application and successful implementation team for the Indiana Rural Schools Clinic Network, which sunsetted in 2020. That now has several fully sustainable telehealth clinics within schools in rural Indiana. So we were among the first cohorts, from the federal level at least, providing these services, and that provided, I think, a lot of valuable insight for me. But of course, every community is going to be different. So you can mold and contort this however you like. But for parents and community members, I think the big thing that they're going to be wondering is what needs are going to be fulfilled by offering telehealth in schools that are not currently being met, right? Like they're going to wonder, what is the value proposition from a purely like, how does this help my child, my friends' children? How does this make my community healthier? And what is this going to, what spaces is going to occupy that we don't already have something for? For providers, you have a little bit more of a nuanced set of needs that you're going to have to anticipate. Obviously, you're going to have to prove viability. You're going to have to demonstrate that you know how digital health workflows work. And the biggest thing, I think, is really clearly defined use cases so that so that they are not going to be concerned about gumming up their existing workflow for potentially superfluous encounters. And then next, we have for the folks who work in the school as well as the students themselves. For administrators, obviously, you're going to have to anticipate liability. You're going to have to talk about all those things and think through those. How staff are going to be allocated, and then finally, the big elephant in the room, cost. And then for everybody at the table, I think there might be some level of skepticism, even though I know we do live in a post-public health emergency world. I still think that there are some people who might question the viability from a purely like clinical appropriate perspective on how telehealth works, especially for young people in a school building. So that's kind of where we're at. When you think you have a pretty good handle on these basic concerns is kind of when I think you start reaching out and putting people in the room to discuss how to implement. Next slide, please. So for the community members, parents, engaged citizens who might just be, who might rightly identify the school as a good, I think, litmus test for the health of a community, right? I mean, generally speaking, especially in smaller rural towns, the school or the local hospital is one of the largest employers in the county. And so, it occupies a very unique space. It sometimes tends to be a central hub of where people get together during not only the academic year, but also over the summer. And for large school districts, this is a place where a lot of people get basic needs met, throughout the academic year and beyond. So you really need to be able to address for these for these constituents here, meaning parents, guardians, concerned community members, et cetera, what needs you're addressing. So you need to establish that need. And for a lot of community members who might not really know what goes on in a school nurse's office or how telehealth integrates in that way, you have to demonstrate that need by showing, okay, our community has said that this is a problem. This is what we are seeking to address, right? And a good place to start is at your local hospital system. And this is true of communities regardless of geography, right? A lot of hospitals, or all hospitals, I guess I should say, have to publish periodically community health needs assessments. A lot of these are done not only through analysis of secondary data sets that they have access to, publicly, but also by engaging in focus groups and sending out surveys. So there is some primary data there as well. And so if you can actually prove that, no, we've already gone through the trouble of knowing that you are concerned about the youth mental health crisis that seems to be omnipresent that we're talking about. We know that tobacco use and vaping is a concern. We know that chronic disease management, particularly asthma and diabetes, is particularly high for this segment of the population, right? If you can demonstrate that you've already done that work, that goes a long way in bringing the community to the table, I think. And if you take nothing else away from this presentation, I guess I should say we here at the UMTRC are like really passionate about this particular component of it. Really stratifying data to find the areas of highest need. That's kind of my personal hobby horse, if you will. So feel free, if you find yourself overwhelmed in this process, to reach out to your local telehealth resource center, which would be us if you are in the 4-state region of Illinois, Indiana, Michigan, and Ohio. Next slide, please. Now the big one, the big challenge, trying to convince providers to come to the table with the intention of providing services. As I said earlier, really identifying those specific use cases for digital intervention is going to be absolutely crucial. So some common use cases include primary care, and this ranges from minor injuries to common acute illnesses, cold, flu, etc. Medication management even. And I think even though the evidence base surrounding school-based telehealth is relatively shallow, I would say, well, at least by comparison to other digital health interventions for adults, this is the most common model, right? Is identifying a local primary care partner who works with school staff to help manage these particular instances. I think obviously one that's attractive to a lot of folks is mental and behavioral health integration into this primary care model. Obviously, there are some limitations there, and we'll go into those here a little bit. Other therapies, nutritional therapy, occupational therapy, even sometimes PT, if there's a particular need there, can be delivered via telehealth. And a lot of that can get rolled up into, regular primary care visits. And some of these qualify more as health education services rather than necessarily clinical intervention. But those are very common. And then finally, yet another very common and perhaps the most robust in terms of the evidence base is chronic disease management, especially asthma and diabetes. Just being able to have access to a healthcare provider should there be a complication that arises during the school day that can easily be managed without having to take that student out of the school, without having to have the parent or guardian come away from work, and not having to miss class time, et cetera, et cetera. Those are the kind of the four main buckets, I think, where you identify the clear use case that when the student presents at the school nurse's office or the telehealth presenter is present, they determine that it is clinically appropriate to go ahead and initiate a telehealth visit. These are the things that you're going to be seeing. Next slide, please. And I think this is the other concern, right? Is how is this going to, from a provider perspective, how is this going to cut into my existing workflow? Does this mean that I'm going to be devoting more time to this when I could be seeing my patients already here in the building in person? Is my patient volume going to go down? What am I held accountable for? How does this affect my malpractice? Am I even licensed to do this? That kind of thing, right? So I think the thing that you have to remind people, and again, this is much easier now in a post-public health emergency world, that digital health has been proven, as long as it meets the minimum standard of care, which is the law in Ohio, that it's safe and it's effective. Now, I'm also not going to be the one to say that digital health and telehealth broadly are panaceas and that it's going to be the cure-all and that it should obviously replace in-person care for all use cases. That's not what I'm saying. I'm not a clinician. I don't pretend to tell them how to do their job. But I do think that it's important to remind them that those clinicians do have the ultimate authority to determine the appropriate level of care. And for a lot of these use cases, provided that you've done your homework and you've provide the very specific ones, that they will ultimately agree that these are manageable via telemedicine. Um, Obviously, reminding them that referrals are a built-in part of any digital health workflow, whether that's to social services or to specialty care or to a higher level of acuity where they might actually need to go into the office or, fingers crossed doesn't happen to the hospital, right? If the brief intervention via telemedicine in the school does not resolve whatever's going on. Um, and then, of course, you're going to have to really reassure providers that their non-medical staff, right, the folks who are actually managing appointments and the physical building itself, that they're going to be consulted on how to be integrated into these workflows. Next slide, please. So yet another population that might present some challenges in terms of convincing the viability of this of a school-based digital health intervention platform is school admin, faculty, and staff. Obviously, they're going to have very different concerns than a local healthcare provider, and they're going to have very different concerns than parents and students. For instance, I know that one of our big challenges in rural Indiana was that there was a pilot program that really wanted to do a universal screening tool of some kind for all 10th graders in a small high school in Scott County, Indiana. The school administration was less than enthused because they were concerned of taking on that liability of, oh, well, if X number of students flag for, say, suicidal ideation or substance abuse, and we don't have the capacity in our local healthcare system to accommodate them, what does that do to us? That's a valid concern. You have to anticipate those things. And it might mean that you have to limit, at least at first, the clinical scope of digital health integration in the school-based healthcare setting. So that's something to talk about. And I could go into any number of other counterfactuals or what ifs, but that is a valid concern. You have to anticipate that. Obviously, coming to the table with some kind of funding mechanism is going to be a huge help. A lot of school districts are already squeezed for budget, and you hear of the stories of folks in the past when state funding to schools was partially allocated by average daily membership, right? And so you'd have school assistant principals like knocking on people's doors, like trying to get kids to come to school so that they could count for their attendance and that kind of thing. So that's obviously going to be a concern, and there will be plenty of opportunities to do so. And we can talk about some of the finer points of that later. But if you can find a way to get a little bit of seed money, whether that's even just paying for equipment, which is getting cheaper and cheaper by the year, that's going to be a big help. And then, of course, reassuring administrative staff, teachers, anybody who might even be remotely tangentially connected to this workflow, that again, nothing about us without us, that you are going to explicitly consult them on how this is going to disrupt as few people's days as possible. Obviously, for students, you need to be able to effectively communicate that this is a safe and confidential process, depending on the kind of work that you're going to be engaging in. So all of your equipment obviously has to be HIPAA secure. You have to be really familiar with FERPA rights and all of the different ways that can interact or not with a clinical encounter. And having that buy-in from local providers and assuring students that unless something really bad happens, this will be available from this hour to this hour on these days, and this will be a viable resource for you to use going forward. Next slide, please. And then finally, I did mention an evidence base, and I also kind of alluded to the fact that, and I think this kind of applies to telehealth broadly, the evidence base is getting more robust year by year, and it really got a shot in the arm, with the onset of the global pandemic. But compared to, in-person interventions, preventions, and other traditional continuum of care that's delivered in person, I mean, we are, decades and decades behind in terms of having that huge breadth and depth of journal articles and studies to be able to determine absolute viability. But there are some things that I think we can definitely demonstrate, even with a relatively in a nascent field. So we know that school-based telemedicine, and we prove this in Indiana in our various implementation sites, that you do save costs, whether that's direct cost of care delivery, or indirect costs, like I mentioned earlier, taking kids out of school, having parents and guardians have to leave work, um, potentially having to drive dozens of miles to the nearest healthcare delivery point. Right. These are all ways of saving costs for the community and making sure that kids miss as little learning time as possible. We obviously know that telehealth, especially when used appropriately and when implemented efficiently, increases access to care to vulnerable populations as well as the population at large. Telehealth is also uniquely positioned to be able to address accessibility concerns and some of the other things that might get overlooked in a traditional in-person care setting. We know that there are multiple studies now that having a digital health option in the school to where kids don't have to leave to go get, um, an antibiotic or something like that leads to better attendance because the script can be waiting for them after school whenever they are dropped off by the bus or their parent or guardian picks them up and they missed very little class time when the proper diagnosis is made, et cetera, right? And we know that it leads to better chronic care management, especially for those two areas I mentioned earlier, asthma and diabetes. But this could apply to any range of chronic diseases that kids might be dealing with. And I guess I should mention as well, we've seen some unique models as well where um, that school-based telehealth clinic might actually serve adults in the community or adults in the school building as well. So this isn't necessarily unique just to youth. And again, we here at the UMTRC are more than happy to point you in the direction of specific literature. I don't know how this got excised. I must have forgotten to include it, but the Northeast Telehealth Resource Center, which is based in Maine, actually has a searchable database that they manually populate and aggregate with a lot of journal articles and such that specifically mention school-based telehealth. And I will provide that link upon request after the webinar is over. Next slide, please. So you've managed to do all the talking. You've gotten everybody at the table. They seem to be bought into the concept. One of the things that you also need to be really clear on is what your technology needs and capabilities are. So we, as a federally funded entity, cannot specifically recommend a particular platform or solution. But if you get to the point where you might be further along in your implementation process, or maybe already have implemented something and you just have some questions about the specific applicability of a solution or technology, we can certainly give you a list of pros and cons. We can't make that warm handoff or say, hey, in our opinion, this one is the best, right? So I'll just give you a couple parameters that you need to be considering. If you have an office space dedicated to the school nurse or whatever your telehealth presenter might be, you need to be able to know that your technology is appropriate for that physical space, right? Obviously, as I mentioned earlier, you need a HIPAA secure platform. And with the proliferation of so many digital health devices and platforms, that's not nearly as difficult to obtain as it used to be, or really to ascertain or certify. So that's relatively simple. The next is selecting your devices, whether that's a laptop or a tablet. If you need additional augmented audio and visual with a microphone and camera, I think one of the big ones actually that we tend to overlook when we're thinking about this is making sure that your broadband connection is reliable and secure, and then having a backup plan should you get disconnected. Right, that's one of the big ones, and especially a huge concern in our more rural communities. And then other clinical tools like remote physiologic monitoring equipment, like a thermometer, a stethoscope, blood pressure cuff, right? That all they might be wireless and linked up to whatever your chosen platform is. Depending on what clinical scope you decide to go with. So those are all questions to ask. Next slide, please. And additionally, when you're considering your technology, you really want to make sure that you're asking these questions. And I've included a link on this slide to what I mentioned earlier, TTAC, that Anchorage, Alaska-based center. They have a tremendous wealth of information about a lot of common platforms and technologies, as well as specifically school-based resources that you can check out. It's an entirely searchable aggregation of pretty much anything you could consider when it comes to technology. And so the questions that I kind of came up with that we had to learn the hard way on when we were establishing the Erskine, that Indiana Rural Schools Clinic network, because each building is going to be different, and they're all going to have different preferences, and they're going to have different scalability concerns, or what clinical scope they're working with. So are you going to have like a mobile cart or just individual tablets? Are you going to have a whole kiosk where, you know, it's completely stationary and there's a designated space for it? Or again, like, do you need to be a little bit more flexible with moving around? Will your internet connection be, you know, directly integrated via the Ethernet cable, or will it be wireless? And if so, how do you test for that speed and reliability? Is this going to scale, right? You know, if you have say a smaller scale operation, do you plan to offer it to other buildings if this is a larger school district? Do you have in-house IT? And if not, how are you going to address any kind of IT issues, whether that be troubleshooting the software or hardware, or any other consideration in that scope? And then does your local provider want to have direct integration to the electronic health record? If they do, then that might influence your platform of choice, right? A lot of places do offer that nowadays, but that's kind of a question for your clinical partner to ascertain, because they have to consider things like lack of interoperability, what the actual EHR is, et cetera, et cetera. Will you need to for tech literacy, right? And accessibility concerns. How are you dealing with younger populations who might not be as familiar with it, or are you dealing with a pretty tech savvy population? You know, I think we all assume that young people, having grown up in this 21st century iteration of the world, do, but you never know, right? So you might want to consider that. And then finally, are you going to have somebody to help facilitate the equipment, or is it designed to only be operated by the patient? And this is especially important for considering mental and behavioral health integration. So just something to consider. Next slide, please. When it comes to personnel and workflow, I can't go too deep into the weeds, but I can, at the very end of my spiel here, I'll give you an example of kind of what a standard workflow looks like and what kind of personnel you need. But every building's going to be different. Every building's going to have access to certain resources, capacity, time, money, et cetera. So I'm not going to be super detailed on this slide, but generally speaking, these are the kind of roles that need to be occupied, and one person might be able to wear multiple hats depending on the size of the school and scope of the project. So obviously you need a school nurse, a school counselor, a social worker, or a telepresenter. Again, this can kind of be a combination of people, or one person, depending on how they're licensed and certified. When I say telepresenter, basically what that means is if you do have some of those remote physiologic monitoring pieces of equipment that they know that they are trained and know how to operate them, you know, that blood pressure cuff, the stethoscope, you know, any kind of other thing that they might be actually using with the express consent of the parent, guardian, and the patient to use. Obviously, you need a local provider, school IT staff, if possible. If not, then that's something that you might need to work around. And I think it's really important to have an on-site telehealth champion. I think most of us who work in the digital health realm know the importance of having an advocate on the ground, like repeatedly saying, I know volume's low, but if we really stick to it, we're going to see return on this investment. or just being able to know how to answer basic questions or know where to direct people when they have a little bit more thorny issues, right? Um, and then having a technical assistance provider. Luckily for everybody who might be in Ohio specifically, the UMTRC is a free technical assistance provider up to 10 hours. And for other considerations, we go well beyond that. So just as a kind of high level overview, these are the personnel that you might want to consider for your implementation process. Next slide, please. So as far as best practices go, you definitely want to, after you've created the buy-in, you've demonstrated the need, you've identified your use cases, and the clinicians are all on board. Perhaps even like during the workflow creation process, but well before implementation, you definitely want to make sure you have some kind of memorandum of understanding or a contract service agreement, something that is legally binding, that says, these are the parameters within which each of the various partners are going to operate, just so that if things ever do get complicated, that you can refer back to it and say, okay, this is what we've agreed to do. If we need to amend this memorandum of understanding or agreement, or amend this contract service agreement, if we want to expand the scope or limit it, there is at least a paper trail that you can go back to. I think obviously one of the big concerns for parents and guardians, as well as school administrators and staff and faculty, is going to be the consent portion. And I can talk a little bit about how we handled this for Erskine here in Indiana. There essentially are two approaches, right? Like, and this will depend on your local healthcare provider who you partner with, or even a more distant provider. It'll basically entail that either you have to get consent before every encounter, regardless of circumstance, and that is a totally viable way to do it. And then you can have something that's more along the lines of an evergreen consent, like you would get at your doctor's office, where maybe it's only yearly, or maybe it only covers the beginning to the end of the academic year, but that if you opt into this service, that serves as consent as long as it's properly documented. So that's what I mean by enrollment, right? Obviously parents and guardians can say, nope, I don't trust this. Obviously make sure that they're informed on that. This is not mandatory. This is not like a sexual education course where they are considered to have already consented to it and have to opt out manually. This is a medical encounter. So those kinds of consents are incredibly important. And if you have questions about maintaining consent or documentation, obviously reach out to us directly as your regional telehealth resource center. Training and continuing education for people who are operating the equipment, for clinical staff, for your program coordinator or telehealth champion, for school administration is going to be a big concern. Especially if people are not necessarily intimately familiar with the way digital health is offered, and the way it actually is provided, you want to make sure that everybody who touches this particular excuse me, this particular project is adequately trained to either operate the devices or to refer people to the folks who are, right. Billing and reimbursement is obviously going to be a big concern, and we'll talk about that here in a little bit. But I will just preface this by saying that some of the school-based health clinics in Indiana that we facilitated using digital health are fully sustainable just by billing for the services that they provide. So that is just a piece to be aware of. And then finally, or not finally, but obviously hand in hand with that is going to be trying to get your patient volume at a place where it feels like this is a viable and worthwhile thing to continue. And that relies almost entirely on spreading the word. That's making sure that everybody's on board before the school year begins, having your clinical staff or your telehealth champion at back to school nights, at counseling appointments when you're scheduling classes, making sure that everybody knows that this is available. For instance, when we were implementing Erskine, I traveled to the northern part of the state and the southern part of the state a lot as a Spanish speaker to specifically inform our Spanish speaking families about the existence of these services. and we saw a lot of tremendous success with that kind of initiative. So there's another bit of a health equity perspective there to consider, translating consent forms, that kind of thing, if you serve multiple language groups, etc. Um, Funding, of course, we talked about. Having some money in hand would be great. We know that sometimes local county coalitions have some money that this aligns with their mission, even if it's just a couple $1,000s to buy equipment. Um, we know that federal grant programs will obviously support this. Sometimes private foundations or private citizen donations will help, depending on how that aligns with the school's, rules and regulations. There's a lot of different mechanisms to do this, but of course, that is its own challenge in and of itself. And I'm willing to talk about that kind of after this presentation. This is just another rabbit hole I don't have time to go down today. Then, of course, expansion. If this works really well and you're happy with the results at the test site or whatever, do you have plans to make it bigger? If you operate in a large school district, say in Youngstown, how wide can you go, right? And what populations are you going to serve? Then finally, you want to make sure that you have a good evaluation plan in place. It's one thing to offer the services, but it's another thing to continually evaluate, update, improve. So an evaluation plan is critical. Having a policy that's very explicit, but is flexible enough to allow some response with alacrity in very specific circumstances for referral and follow-up is going to be big. And that will be obviously hand in hand with your clinical provider. And then finally, being able to ensure privacy. These are still health encounters, even though they're being conducted in a school setting, and ensuring that this is confidential and follows all the primary concerns of standard of care in the state of Ohio and beyond is going to be a major concern. So that's kind of a high level overview. We'll move on to the next topic here. So next slide, please. So billing and reimbursement. This is kind of the operative issue for so many digital health programs, paradigms, initiatives, whatever you want to call them. I have included a link here to the specific Ohio-based resources, but you can poke around the website for all 4 of our other states, as well as some more universally applicable nationwide stuff and some sample workflows, et cetera, et cetera. But for your clinical staff, especially their non-medical staff who might be handling billing and coding, we have a 20, I think it's like 28-page guide that breaks down the payer matrix in terms of like what services are are covered by which private insurer, what Medicaid covers, and that can be found in the link on that first bullet point there. So that's going to be something that you definitely want to anticipate as a concern from your local provider. But luckily, we've got you covered on that front, and you can use that document, which will actually have an update published here at the beginning of June. So there hasn't been a whole lot of legislative and regulatory movement in Ohio specifically, but nevertheless, we will be combing back through that to make sure it's up to date. And obviously, reimbursement rates are kind of non-negotiable for many of these. They're pursuant to the physician fee schedule that gets published at the beginning of every calendar year, in accordance with the Consolidated Appropriations Act that began specifically for telehealth expansion at the onset of the pandemic. And then finally, obviously, private insurers all bill differently and cover differently. Even though I guess I shouldn't say cover differently. There is a coverage parity law on the books in Ohio, but there's not a payment parity law. So everybody could potentially do things just slightly different. Some require a certain modifier, et cetera, et cetera. And again, that's something that we can definitely help you out with. I didn't want to go too far in the weeds with that because I could spend the whole hour on just billing and reimbursement if I wanted to. So something to keep in mind, this slide is really important. Some great links, good resources, and you can reach out to us directly if you have further questions. Next slide, please. As far as legal and regulatory concerns, obviously, we talked about some of the really kind of, specific worries that school administration might have or what parents might be concerned about, that kind of thing. And that, all comes down to HIPAA and FERPA and making sure that you have a really solid understanding like what kind of information is protected and how to ensure the privacy of the patient, and how to get explicit consent and what patients' rights are even in a digital health setting. Um, then, one of the things that's tangential to this, but definitely could be resolved through your school IT partner, is going to be cybersecurity. Um, Increasingly we're seeing healthcare as a point of vulnerability, especially with protected health information at stake here. So making sure that that's at least being thought of in the back of your mind throughout all of this implementation is going to be a key concern. Your local provider is going to be concerned about malpractice, and I'm sure that their legal team can kind of walk you all through what they're covered for and what they're not. And we've not had much of a problem navigating any kind of malpractice concerns from our end in Indiana, but I wanted to make sure that I put it in there just in case it is a concern, something to anticipate. And then finally, of course, liability. When you take on a particular clinical scope of work, what are your liability concerns when you're dealing with young people? And there are a lot of resources out there, from the School Nurses Administration or School Nurses Association, other professional work groups. I'm sure the Ohio Medical Association probably has some guidance on this as well. So those are all valid resources to look into. Next slide, please. So how does it all work? You've done what you think is the preliminary work. You've gotten people to the table. You think you've got a good workflow in place, et cetera, et cetera. What does it look like? Next slide, please. I've included links to some successful models in 3 states here: South Carolina, Indiana, and Ohio. Obviously, Indiana being geographically proximal is going to be a big help, I think. Southern Indiana Health Centers is the one that I chose. They work in Orange County, Indiana, which is a highly rural community where the county seat is Paoli, but that's actually where French Lick is as well. And yes, thank you, Reen, for posting those links. The South Carolina model, I think, is good for you to look at because it's very robust, but it doesn't necessarily apply to every community because they are partnering with the Medical University of South Carolina, based out of Columbia there, and Charleston. So not everybody has a university medical center that they can partner with, but they work in conjunction with one of the telehealth centers of excellence. So they really have a good handle on a lot of this, and there are some good universally applicable lessons for how clinical encounters work, how providers can improve their website manner with kids, how to work in a school building, et cetera, et cetera. The one that I included here from Ohio is actually a community center based out of Mansfield. And I guess for what it's worth, you all should know I'm pretty intimately familiar with Ohio too, as I graduated from Wright State University in Fairborn, and have friends all over the state, from Columbus to Cincinnati up to Akron, Toledo area. My mom's family is all from the Lima Van Wert area, so very intimately familiar with the state. And the Mansfield model is really neat because they've managed to really integrate it as just part of the healthcare system. So they serve not only the kids in the building, but also it serves as a walk-in telehealth clinic for community members as well. So that's an interesting model to check out, and one local to whatever demography you might be serving. Next slide, please. So like I said, this is what I promised. This is kind of the basic model. And I actually, just to cite my source, I did take this from your national organization, which is the National School-Based Health Alliance. And because we actually, when we were doing the Erskine model, used a similar workflow, a similar kind of flow chart here. So basically, this is the most common way. A patient, in this case, usually a student, goes to the school nurse's office for some kind of complaint, right? And that drops down to the next level, where the school nurse will evaluate them, whatever it is that they need. And they will decide if there's a clinical need for a telemedicine consultation. In which case, if you've already established that partnership, they will page the provider. If it's within those documented hours that they have contracted to work, they will pop on, whether that's the tablet or the kiosk or whatever. Again, this is where you have to decide, is that going to be mobile? Is that going to be stationary? You know, how have we already gotten consent for this, et cetera. And then then that clinician will uh, come in via the audiovisual platform. They will, you know, get the digest from the school nurse. They might do a remote examination if you do decide to buy some of that remote physiologic monitoring equipment. They might make a recommendation for a prescription. They might actually refer to a specialist or a higher level of acuity of care. And then they will document that encounter just as they would any other in-person encounter. All of the same rules and regulations for standard of care when it comes to documentation purposes for telemedicine, pretty much throughout the country, but specifically in Ohio, the administrative code is very clear about this. All of the same documentation standards apply. It's also particularly important for telemedicine encounters for billing and reimbursement, because you have to be able to document the location of the patient, which determines which modifier you use, et cetera, right? And so then the provider will obviously document all that, maybe send out the prescription, and then usually best practice is to have a follow-up with the patient's family and ask, you know, hey, you know, if we referred you to somebody else, did you go see them? How did that go? Is everything okay? And then, you know, at the end of it's also best practice in our experience, every semester or sometimes once a quarter, even, you know, whatever grading period you want to use throughout the academic
Is this
year,
all related to workforce development?
to absolutely you know, kind of evaluate whether or not this is effective, right? So that just having those periodic check-ins is going to be huge. So this is really like the kind of basic model, and you can kind of bolt on extra bits to this if you like. You can streamline it even further if you like, if you're just offering a very specific and narrow clinical scope. And obviously behavioral health integration, if this is not just primary care, is going to take extra consideration, especially if you have a lack of a local provider. But all of this is going to be following something along these lines as a kind of baseline model. So I will pause there. I realize we're getting close to time. So next slide, please. I think we just have time for questions very briefly. If I don't have the answer for you immediately, I will make sure that I get with the Ohio team here and respond as quick as I can.
Feel free to raise your virtual hand or pop a question into the chat box.
Yeah, I think chat or the chat or the Q&A function, I think both work fine, right?
We just have chat option here.
Got it. Okay.
But I'm not seeing anything coming into the chat.
I tell you what I'm gonna do, Reem, is I'm gonna put my personal email address in the chat, just so that if anybody thinks of anything later, they can take that down. And of course, feel free to send out my contact information with the follow-up. So we have a question from Jody. Does this telehealth also apply to mental health consults when psychiatrists are needed? Broadly, yes. You know, the biggest concern with behavioral health integration in schools is getting the buy-in of the administrative staff, because you know it's so difficult to convince folks that you are alleviating them of any kind of liability, depending on what can of worms might get opened, right? So if a psychiatrist is needed and one is not available, or you don't have a partnership with a psychiatrist's office as a clinician, not just like a licensed clinical social worker or something like that, that's kind of the gray area that you definitely need to navigate. I'm happy to talk about talk with you maybe as a follow-up, because I know we're getting close to time. Jody, if you want to send me a message to talk about how we alleviated some of those concerns in Southern Indiana. But yeah, it's complicated. But broadly, yes.
Thank you so much, Luke, for that great and informative presentation for folks on the call, we will be sharing a recording of this presentation and then also the slides for your reference. Pop your email into the chat. Of course, you can always connect with the Ohio Alliance team, and we are happy to route your questions to the Upper Midwest Telehealth Resource Center as well. Before folks go, we hope you enjoyed this presentation, and go ahead and move to the next slide. Want to make sure that you take our quick poll to ensure that we met our objectives. Oh, and here's all the if we can go back one more slide, just want to make sure that these are all the ways that you can connect with the Upper Midwest Telehealth Resource Center. So if we can just go back one more slide. There we go. And then that lunch and learn evaluation has also been launched. If you're able to answer these 2 questions for us. We are always looking for ways to improve in the resources and support that we provide to all of you. So please do take that quick poll for our own learning and quality improvement.
And just to reiterate what the Alliance team was saying, I'm available directly, or you can go to our website and poke around and submit a contact us request. It'll all get back to me somehow. So if you want to go maybe further in depth with some of these things, including maybe how to sustain a program once it's begun, we have a lot of resources for all of that, and I'm happy to talk about any of that after this is over.
Thanks so much, Luke. And we'll be following up with you. We may want to do kind of a second lunch and learn for those that want to get a bit deeper into these topics. Following up, there might be interest in that. Go ahead and move to the next slide. We want to make you aware of, there might be a little bit of a lag. If we move to the next slide. Are we able to move to the next slide? There we go. We want to make sure that you are aware of our next Lunch and Learn, which will be focused on, go back one, which will be focused on a trauma-informed lens in school-based healthcare delivery. So save the date for Thursday, June 20th. And we certainly encourage you to also join our newsletter. And we can pop that link into the chat. If Phoebe or Rachel can pop that link into the chat to sign up for our mailing list, you will get all of those announcements and updates. Next slide. I think we might be having a little bit of an internet lag. And then these are the benefits that you can take if you are a school-based healthcare partner if you join as a member of the Ohio Alliance. So we focus on policy advocacy and funding, capacity building, and then you will get priority communications and visibility. So we encourage you, if you're a school-based healthcare partner, either a school-based healthcare provider or a school district, to consider having your organization join as part of the Ohio Alliance. And with that, we'll go ahead and end our Lunch and Learn today, and appreciate all of you joining and hope that you informative presentation conversation as we have at the Ohio Alliance. So thank you very much, and we look forward to joining our other Lunch and Learns. Thank you, Luke.